So good afternoon, everybody. My name's Emily Pearson and I'm the founder and managing director at Our Minds Work. And welcome to Supporting Female Employees Through Hormonal Health, our little webinar today that we have with special guest Sharon MacArthur, or Miss Menopause, as many of you may know her, and my colleague Emma Carhart, who's joining us for the session today. So let's get going. I just want to tell you a little bit about Our Minds Work for those of you who don't know who we are. Our Minds Work exists to help HR professionals to develop and deliver impactful mental health and wellbeing strategies. And we do that through three particular services. We have our level 5 mental health and wellbeing culture change diploma, which is happening. It's enrolling now, happening in September. And this is specifically for HR professionals and wellbeing leads, or anyone else with wellbeing strategy design and delivery as part of their role. We also provide a level 3 prevent stress and support mental health course for managers. This is specifically for people managers, giving them all the knowledge, skills, tools, and confidence to create mentally healthy workplaces by preventing work-related stress and fostering cultures of well-being in their teams. And we also provide a 12-month workplace wellbeing membership. This is where we work with you for 12 months with strategic consultancy. We also provide half-day workshops to help to develop your mental health first aiders, advocates. And we also deliver a host of wellbeing webinars as well for employees. So that's what we do at Our Minds Work. But I am going to hand over to Emma to introduce herself, and then I'll give a little introduction to our special guest.
Hello there, good afternoon and a very warm welcome this afternoon. My name's Emma Carhart and I work alongside Emily for Our Minds Work, and my title is Workplace Mental Health Educator. So I'm delivering the training solutions, one of which we're seeing this afternoon. So thanks, Emily.
Thank you. And a huge welcome to special guest and a personal friend, Sharon MacArthur, or the very well-known Miss Menopause. Sharon and I have been working together in the workplace mental health and wellbeing field for a very, very long time now. If you know Sharon, you'll know how unique and special she is. If you don't know her, by the end of this session, you will also know how unique and special she is. So Sharon, tell us a little bit about how you became Miss Menopause and what you're doing in this space.
Well, thank you so much, Emily, for having me this afternoon. So I was an angry menopausal woman. That's all I can describe myself as. And 7 years ago, I set up Miss Menopause to make menopause business as usual. So that's really what my mission is. And ultimately, I hope one day I'll be made redundant because menopause will be business as usual. But right now, I think we've got a bit of a void of ignorance still to kill before we get there. So I'm really delighted to be here this afternoon.
Wonderful. Thanks so much. I'm excited to have you join us today. So let's jump in. Just a little bit of a scene setting really for you. We have been running a little bit of research with our mental health and wellbeing maturity assessment. So we've had over 150 wellbeing leads and HR professionals complete this up to now. And one of the questions we ask is around your strategic wellbeing pillars. So obviously mental health, improving employee mental health is one of the major pillars. But we also asked, what other pillars do you have? And 17% of our wellbeing leads said that menopause-friendly workplaces and physical health and work-life balance were three major pillars in their strategic wellbeing activities. So we know it's important. We know it's on the agenda. We know it's definitely been trending over the past couple of years. So we're here to do a little bit of a deep dive into that. So in terms of what we're going to be covering today, we're going to run a quick poll in a couple of moments. Just 2 questions, just gives us a little bit of insight into what you know around PMDD and what you're actually doing around menopause in the workplace so far. Emma's then going to lead us in explaining what PMS, premenstrual syndrome, is, and identifying it and how to manage it as well, manage the symptoms. The reason that we cover this is to help us to lead into PMDD, so that we can really show you the significant difference between PMS and PMDD, because they often are used interchangeable. However, they're very, very different in terms of what they are, especially when it comes to the severity of symptoms, the treatments, the diagnosis, and also how workplaces will be legally compliant in following the Equality Act in terms of providing reasonable adjustments for anyone who has a diagnosis of PMDD. That will link us into how PMDD, unfortunately, gets worse during perimenopause, and what are some of the challenges connected to that, before we hand over for the rest of the session to Sharon. So we're going to take a little bit of a hormonal journey today from PMS to menopause. So strap yourself in and let's jump in. Emma, can you just launch the poll for me, please?
I certainly can.
So the poll should just pop up on your screen as if by magic. And there are 2 questions for you to answer. Shouldn't take you more than a couple of seconds, and then we will get some feedback on that.
Well, I'm sorry, it's just been a little bit sticky, and let me share this because it's been up on the screen before. Let me try it again.
All right, Emma, I think I've done it.
Okay, good stuff. Thanks, Emily.
No problem. So there we go. The poll is up. Question number 1, how much do you know about premenstrual dysphoric disorder? Question number 2, what menopause-friendly initiatives have you implemented so far? 2 pretty quick, simple questions just to get a bit of understanding of your level of knowledge around what we're covering today, what you're already doing so far in terms of well-being at work on menopause. So we've just got a few more people left to complete the poll, and then I'll share the results, which are looking very interesting at the moment. Okay. It looks like everybody's completed that. So I'm just going to end the poll and share the results. Here we go. So question number 1, how much do you know about PMDD? 24% have never even heard of it. So brilliant that you've decided to attend today. You'll definitely learn something new, which hopefully you can take away and start sharing some of this information. 52% have heard of it, but that's all. 24% saying I have some understanding. Nobody in the room say I think or I have PMDD. I do. So there you go. You now all know at least one person who has that. And I think, Emma, if you'd had the option to do that, you might have ticked that box as well.
Absolutely, yeah.
What menopause-friendly initiatives have you implemented? So we've got 28% saying nothing at all yet. 20% have a menopause policy. 8% have done menopause training for managers. 16% have menopause champions. 20% have a menopause CAF running. And 8% has menopause support and education. So really interesting to see where everybody's at in terms of what their workplaces are doing. So I'm sure Sharon will talk a little bit about some of those answers a little bit later. So let's get going. Over to you, Emma.
Sorry, I just muted myself again. Thank you, Emily. So yeah, what I want to start with on this journey, is hormonal journey, is PMS and the impact potentially on an individual, and bringing it into the workplace as well, and looking at how you can possibly support individuals within the workplace experiencing that. So if I have a look, first of all, at identifying, what do we understand PMS to actually be? So as many as 80% of us experience some form of PMS in the second half of the menstrual cycle. And considering that we all have, we all menstruate on a monthly basis, that's a lot of people who are affected by that. So what kind of effects? We'll have a look in a second. It's a collection of emotional and or physical symptoms, including bloating, breast tenderness, increased hunger, weepiness and irritability, as well as the physical symptoms as well, which can be pretty impactful and difficult to deal with. Mostly when we're looking at this, it's not classified as an emotional and or a physical, it's not classed as a mental illness in the Diagnostic and Statistic Manual, the DSM. It's more so known as a collection of symptoms, which is called PMS, premenstrual syndrome. And the reason I'm highlighting that is because when we talk a little bit later about supporting an individual in the workplace, the Equality Act 2010 looks at mental health conditions as disabilities. However, PMS, because it's not classed as a disability, it doesn't occur in the DSM, therefore it's not classed as a disability in terms of asking for reasonable adjustments. However, impactful symptoms. So let's just have a little look and see what's actually happening during this time and what potentially causes it for anybody, 80% of women who are experiencing this. So I'm going to take you back to 101 biology at school, if you can remember that far back. So what we're looking at here is a very simple graphic of our cycle, 1 to 28 days, 1 to 28 of a female's reproductive cycle. So starting at the beginning on the left-hand side, you've got day 1, menstruation, when a woman has a period. Lasts about 7 days, 5 days, 7 days. Can you see we've got estrogen tracking and the levels of estrogen tracking up? So it's increasing, and it reaches ovulation, which is around about day 14. So that's what's going on in the first half of our cycles. And estrogen has a purpose of preparing the body, the reproductive cycle, for pregnancy, basically. And then when we hit ovulation at day 14, that's when we see a dramatic decrease of our estrogen levels. It's a natural process. All of us women go through it. And then we see the progesterone starting to increase. So we've got a peak of progesterone kind of halfway through that second half of our menstrual cycle, and then it dips. And then it brings us back to day 28 again, which is when we start our periods again. PMS, premenstrual syndrome, and those symptoms tend to creep in kind of day 5, day 3, 3 days, 5 days prior to that day 28. So that's when a woman will feel those symptoms, those emotional symptoms, those physical symptoms, which can be unpleasant and difficult to manage as well. So what we wanted to do was kind of show you some information and share I think the guidelines from the NICE guidelines, or the NHS guidelines, Emily, isn't it, on the next page, about managing premenstrual syndrome. So remembering that we've got those physical symptoms, those emotional symptoms, we can actually manage them fairly easily with simple lifestyle changes. So a bit of information sharing can help us. So things like exercising regularly, eating a healthy and a balanced diet, careful with the use of sugar and caffeine, alcohol restriction and smoking cessation if it's applicable for an individual. And also getting plenty of sleep and trying to reduce your stress levels, because there's that awful word again, stress tends to exacerbate all sorts of signs and symptoms that we might be experiencing. And using kind of over-the-counter pain relief as well. Can kind of help with any problems that people are having with cramping and bloating and things like that. But all in all, those symptoms are typically manageable by a woman. They're unpleasant, yes, they're unpleasant, but they are actually manageable. You might want to speak to your manager if you're experiencing things like, quite frequently and quite impactful, and they can maybe have a conversation about supportive measures with you. What I'm going to hand over to Emily to discuss now is a whole different beast. It's a whole different beast, Emily, isn't it? Pre-menstrual dysphoric disorder. So I wanted to share that kind of graphic with the estrogen and the progesterone, because you're going to see a very big difference in terms of what's happening with somebody experiencing PMDD. So over to you, Emily. Thank you.
Thanks, Emma. Really great, just kind of teasing us in gently so that we can really understand PMDD. I think everybody in the room will know what PMS is, and they'll have probably experienced it at some part of their hormonal reproductive cycle over the past however long we have been alive. So let's move on to PMDD. So premenstrual dysphoric disorder is a hormonal-based mood disorder, which unfortunately a lot of women are suffering from, and they just don't know about it. I will be sharing a little bit of my own personal experience of this, because I've gone through the whole process of not knowing what it is, trying to get a diagnosis, treatments, and the major impacts of treatments that haven't worked through a 10-year period of time. So PMDD is a cyclical hormone mood-based disorder. And I'll show you how the symptoms come on with that chart again in a short while. But as it's cyclical, it's impacted by our hormones, and the significant impacts are based on mood. What they suspect, and this is because there's hardly any research at all about PMDD, across the whole of the world, there are only 5 current research studies on PMDD specifically. Now, we could probably talk all day about what if that was a man's health issue. There may be a little bit more research being put into it. However, there's very little research, and it was actually just admitted into the Diagnostic Statistical Manual in around about 2019. So this is, you know, very, very new in terms of medical professionals even understanding what it is. So it's suspected to be a hormone sensitivity disorder that happens inside of the brain. It affects around 5.5 to 8% of females of reproductive age. And I am in that 5.5%. So I'm hoping to share a little bit about my journey. Symptoms are so severe that they have a serious impact on your mental health, your physical health, your well-being, your work, your relationships. And the way that I kind of look at the chart, you know, when we look at where the symptoms are and when the symptoms stop, once those symptoms stop, you then have round about 2 weeks where you start to try and solve the problems that were actually created of the 2 weeks of experience in PMDD, picking your life back up again, solving, you know, the relationship issues that may have been caused by the significance of your symptoms. These symptoms can also lead to addictions. Human beings, animals, mammals, we use coping strategies to deal with high levels of emotional and physical pain. And we actually see addictions increasing in women with hormonal issues. We also see them spike in midlife when we have perimenopause kicks in. And we also see suicide rates spike at the same time as well. Suicidal thoughts and suicidal attempts are also a significant symptom of PMDD. So, as I mentioned, PMDD is classified as a mental health disorder in the Diagnostic Statistical Manual. It was just put in 2019, and that's because of the severity and the impacts on mental health. What that means for an employer, for a workplace, is if a woman even thinks that she has PMDD, then we need to follow the Equality Act, because this is a long-term condition. This is something that will last for years and years and years for a woman. And as I said, it becomes cyclical every month. So in terms of the symptomology, a diagnosis of PMDD requires the presence of at least 5 of these symptoms that I'm going to show you, one of which must be a core emotional symptom. One of the issues around this is because it is so new, women are often, and individuals who were assigned female at birth as well. Sorry, I should have probably kind of set the scene with that at the start. Many women have been misdiagnosed with bipolar disorder. Many women don't get a diagnosis at all, and it takes on average 12 years for somebody to get a diagnosis of PMDD. So this is the core emotional symptoms that we're going to go through. But as I said, if you are recognizing any of these, then you are more likely to know what your experience is. It's something that I knew within myself once I understood what the symptoms were and I tracked them and I saw how they were related to my cycle. So the core emotional symptoms, mood and emotional changes. Now, I'm not just talking about getting a little bit moody and a little bit irritable. I'm talking about severe depression that will come on like that. That means you can't get out of bed. you can't stop crying, you feel like you want to hurt yourself or take your own life. So really significant emotional changes, and also high levels of anxiety as well, even down to having panic attacks. So quite significant in those core emotional symptoms. Irritability, anger, and increased interpersonal conflict. So if you can imagine, you know, I think there's a meme going around I always know when my period's due because I want to kill my partner for just breathing. You know, absolutely hilarious, but actually in the reality of PMDD, that anger and irritability can have significant impacts on your relationships, you know, both inside the home, this could be children, your partners, your friendships, and even at work. As I mentioned there, that depressed mood, feelings of hopelessness, feelings that it's never going to go away, feelings of worthlessness, and feelings of guilt. That anxiety that I talked about there, that high levels of stress, physical tension, being really kind of keyed up, on edge, and like I said, even leading to kind of panic. One of my major symptoms would be anxiety, and still are today. And I've been known to be halfway through doing my shopping, and all of a sudden it'll just come in and I've walked out, leaving all my shopping behind to get in the car and come home before. So these are really, really significant, impacting your ability to carry out normal day-to-day activities. So at least one of those must be core symptoms. I probably had I had 3 of them. I didn't have so much anger. I was more kind of, I internalized a lot of my symptoms with really significant depression, low mood, feelings of self-harm as well, rather than it being outwards towards other people. Then we've got other emotions as well, and other symptoms. So decreased interest in your usual activities, more than happy to just hole up in bed, not want to see anyone, not want to do things that we would normally enjoy. Brain fog, which we've all heard of a million times with menopause. You know, big symptom of hormonal changes is that brain fog, difficulty concentrating, focusing, or even just being able to think straight about things. Now, this says tiredness or low energy. What I experienced was more of heavy fatigue. It would feel like my body was made of lead, and even just doing normal things like getting up and getting into the shower would feel like an absolute mission. Changes in appetite, especially with food cravings, overeating and binge eating. This was also one of my symptoms, and I put on a lot of weight during that time when the symptoms were at its worst. And binge eating until you wanted to be sick. It was almost like you were out of control and unable to stop those food cravings and need to eat. Hypersomnia or insomnia. So this is a lack of being able to sleep, or hypersomnia where you want to sleep more, or insomnia where you're struggling to sleep. For me, it was hypersomnia. I could manage to sleep about 9 to 12 hours when I was experiencing PMDD symptoms. Feelings of overwhelm and being just out of control. And I think one of the symptoms that isn't mentioned in here that I definitely experienced was a dysphoria around how I looked. I feel pretty happy with the way I look most of the time. Obviously, like a lot of us would like to lose a little bit of weight and take action on that. But when I was PMDD, I would actually look different in the mirror. This big dysphoria that I would experience about the way that I looked as well. So other physical symptoms, such as obviously breast tenderness, swelling, joint and muscle pain was a big symptom for me, bloating and weight gain. And that joint and muscle pain again was really significant in terms of physical pain. So as you can see, those symptoms are very, very different to PMS. And also how they're very, very different to PMS is when we look at where PMS is, a couple of days, pretty manageable symptoms. PMDD is also even more significant in terms of the severity of the symptoms and the length of the symptoms. So because our brain starts to respond to our hormonal changes. One of the biggest hormonal changes that we see during this time is after ovulation, this massive spike of progesterone. One of the treatments that I was provided by my doctor, who didn't really know what they were doing, was they gave me a progesterone only pill. Within 3 days, I was suicidal. So we know that progesterone plays a big part in the symptoms that we see related to PMS. And what I just want to kind of talk about is just for a couple of minutes. This is the letter I received on the 27th of June from a hormone specialist doctor who I specifically asked to be referred to after my local GP had been what I felt like was experimenting on me. My symptoms of PMDD started when I was 38, and I remember the day that it started like it was yesterday. I was at a friend's house, and all of a sudden I just felt this huge level of anxiety in my body, like something was wrong. And I made some excuses, said I'm not feeling great, and I went home, got into bed, and I cried solid for about 3 hours, and I knew that that wasn't normal. My mood didn't just pick up the next day, and I've worked in mental health and social care for over 20 years. So I knew straight away that something different was going on with my mental health, my emotional health. This then started to happen every month, as I showed you on that chart there, for 2 weeks, every month, for 18 months, before I managed to get a referral to see the specialist doctor. During those 18 months, my GP didn't give me a diagnosis. What they did was they tried a progesterone-only pill, which made me suicidal. They said, why don't you have the Mirena coil? It's got a little bit of estrogen in. It should make you feel better. I was, desperate. I would have tried anything. Tried the Mirena coil. Within a week, I was on the phone. I'm coming down. You need to take this out before I kill someone. I felt these huge amounts of uncontrollable rage. They then, instead of putting hormones in my body, decided we maybe need to take them out. So I was then given the GnHR analog, or Prostrap, and this is where they put you into medical menopause, chemical menopause. You get an injection every month, and that puts you into menopause. So now, instead of experiencing PMDD symptoms, I now just experience menopause every day, which for me was actually just as horrendous, because there was no hormone replacement treatment to replace what had just been switched off. So that didn't work for me after 4 months as well. By that time, I was so desperate and sick of the experimentation, I asked them to refer us to a doctor that I'd found, who was a female hormone specialist. Her advice and guidance, as I went in, crying my eyes out, PMDD and as well, desperate for some help, was to change my diet, get some exercise. All of those PMS ways of managing those symptoms. So as you can imagine, the level of advice she was giving me in comparison to my symptoms, and I'd been through all of these other treatments, I was just like, gosh, maybe she's right. Maybe it's something I'm eating. So I went away and became super obsessed with the gym, super obsessed with the keto diet. I cut sugar out of my diet, alcohol out of my diet. I was in the gym twice a day. Anybody who knows me knows that I get a little bit obsessed with things. It's definitely part of my personality, and I throw myself into things 100%. So I did that, and I felt amazing for the 2 weeks when I didn't have my PMDD symptoms. I was in the gym. I felt great. I'd lost loads of weight. I was just about to get married, amazing time of my life, which was back in 2019, when I was just about to get married. However, my PMDD symptoms had not gone away. They had minimized a little bit, so I didn't get any feelings of wanting to self-harm. I wasn't binge eating anymore. And I also, wasn't feeling suicidal. So they had come down a little bit, but they were still unmanageable. What happened then was I felt, well, I've been to the specialist doctor. What am I supposed to do now? It's still, I've gone through everything. There is no hope left for me. So I took my health into my own hands and started to use ketamine to self-medicate. So ketamine is used as a fast antidepressant. And I found that self-medicating with ketamine actually took all of my symptoms away. Within 10 minutes, they were gone. I self-medicated with ketamine, absolutely, without any issues, with no PMDD symptoms for around about 2 years until the pandemic hit. Once the pandemic hit, the stresses of isolation, being on my own, my business nearly going under, it was very full of anxiety for me. Those impacts then led to me self-medicating with ketamine even further to deal with the day-to-day stresses, not just once a month, and it led to a 3-year addiction. I'm now 12 months in recovery, and I went back to the doctor because all of my PMDD symptoms came back within 6 months of abstinence from ketamine. And they're not as severe as said here, but I've gone through all those treatment options, that there's nothing left for me now other than to take some propranolol if my anxiety gets too much. She has mentioned taking antidepressants, but I don't feel like they're necessary if I can manage the low levels of symptoms. Why I'm sharing this with you is because it is unacceptable that we now know about PMDD. Women should not be suffering for 10 years to the point where we're struggling with addictions. It's impacting our relationships. It's stopping us from working. When we know that there is support out there, and we'd really want to just share that story so that we can help you to find support. If you are experiencing any of the symptoms that we've talked about, we recommend using a period tracker to track your cycle and your symptoms for a minimum of 3 months. Taking all that information to your GP to show them. And if you think it's PMDD, tell them that that's what you think it is. It's really important that you have a self-care plan. I didn't really have a self-care plan because I was just kind of, the symptoms were so severe, I wasn't actually dealing with them very well. But preempting it, self-care planning is going to be a huge way of dealing with those severity of those symptoms, especially when you know that they're coming up, especially at work. If you've got work to do, how do you manage your work and life around that? We're going to send out some resources afterwards. It's really important that you educate yourself on PMDD. So we'll send out loads of amazing information and research for you to educate yourself around that. Again, I know it's not ideal, but visit your GP. You can find specialist doctors as well online. And again, we'll send you information around that through the International Association for PMDD, for pmd.org. There are also peer-to-peer support groups of other women who are going through the exact same thing. They're on Facebook, they're through the PMD organization as well. So finding other women who are going through this will help you to realize you're not going mad. If you do have symptoms of self-harm and suicide, definitely think about creating yourself a safety plan and talk to your loved ones, including your children, about what you're going through, because it impacts the whole family. And what kind of things can your family do to support you and help? We're also going to send you a PMDD guide of what support you can find and access at work as well. And as I said, it is a long-term condition. The severity means it is going to impact people at work. And the response would be following the Equality Act, to work with your colleagues to find ways that they can stay well at work, but also providing reasonable adjustments where it's required as well. The link into PMDD and perimenopause is that the hormone fluctuations during perimenopause increase even more. So if you already have PMDD and you're approaching your 40s, it is potentially going to get worse. And I think that's why my symptoms became so severe in my late 30s, early 40s. So it can get rough for a little while. Like I said, again, don't suffer alone. Try and get all the support that you can find. Treatments didn't work for me, but they may work for you. Other treatments do work for a lot of women as well. Good thing is postmenopause. Yeah, there's something good about postmenopause is that your PMDD cycling goes away after you're fully menopausal. So yeah, there is a good thing about postmenopause after all. You know, I hope you have found that interesting. You've learned a little bit about PMDD, but it really just links us into where we are at today in our cycle now, which is up to menopause. So without further ado, let me hand over to Sharon MacArthur, Miss Menopause, to share.
Thank you very much. Well, my part is a slide free zone, and all I'm going to say is thank you, Emily. How do I follow that? And I just want to thank you for being so vulnerable and telling your story. And what I talk about a lot is, I think the stories that each and every one of us hold, I call them the gold dust that sit in everybody's business. And if we can create a culture in our business where everyone is enabled through psychological safety just to be open and tell their story, will be a whole lot better because of it. So I thank you for that. So I'm just going to gallop through as best as I can some information about menopause and really talk at a very high level why I think there's a lot of fear and complexity out there in the marketplace, and how I think it could be really, really simple and a lot more easier to do. And it's really interesting with our new government change. They're written something called the first 100 days, and it's actually written into their document that they're talking about menopause for any company over 250 employees, that they're looking at as something. So if you haven't got something now, the government may come along and say you need something. But let me talk to you about what menopause is. So did you know women could spend up to and over a third of their lives in menopause? Now, I often get a groan when I say that, but the good news is it's actually because we're living longer. So if you wind back to 1900, you'd actually find that life expectancy was pretty rubbish. So men were only living on average till they were 47. And women weren't too far behind. They were living to average age of only 50. So we've actually in the 21st century reached a phenomenon where we're actually outliving our ovaries, if you think about it. So because of better healthcare, better nutrition, better housing, etc., we are living into our 60s, 70s, 80s, and often beyond. Now, changes to pensions have meant and will continue to mean that women are working longer in the workplace than ever before. Now, I can hardly believe it, but I recently turned 56 and I keep saying I thought I'd be dead by now. Now, that's only because as a teenager, I don't know about you, but I thought as a teenager, anyone over 50 was ancient. And obviously now I think they're wonderful. But my pensionable age, I was led to believe I would get a pensionable pension at the age of 60 until fairly recently, when the gorgeous government decided they would extend everybody's pensionable age up to 67. So what I want to say is that any younger people on this call today, guess what direction of travel your pensionable age is heading? Well, it's only going one way. So that means women are having to work full-time longer than ever before in history. And this isn't just a UK phenomenon, it's a worldwide one. Did anyone see them write in France for an extra 2 years? So maybe hashtag be a bit more French is what I say. And the fastest growing demographic in the UK, and interestingly across the G7, is estimated to be women aged 50 plus. And if we're also to believe what the press keeps telling us, that apparently here in the UK, we've got more vacancies than good quality humans to fill them, who can ill afford to lose a good quality member of staff out of ignorance? Because that's really what we're talking about here, because nobody's actually told us anything about it. The other scary statistic is every single reproducing female on the planet will become menopausal at some point in their life, usually no later than 55. So this is why I wish to come back as an indoor cat. What can I say? We've got Emily telling us things about PPMD, and I've got menopause coming along. And that's a really, really shocking statistic. So if you think about it like this, I'm sure most people on the call have been doing very, very good work around mental health and well-being. Quite rightly so, you need to continue that brilliant, brilliant work. But if you put mental ill health in the ring, metaphorically with menopause, it would be a full-scale knockdown every single time by menopause, because what percent is menopause? Well, it's 100%. So if you think you've got mental health and wellbeing covered, and also it cuts across ED&I initiatives, you've got a big, big hole if menopause is not being talked about in your organisation. And I don't want this to just be solely, now I'm going to use a phrase, it's actually my least favourite phrase, I might tell you. I don't know if anyone else has used it. I have, hands up. Women of a certain age, I would like us to be discouraged moving forward from using that phrase, because technically menopause could happen to women of any age. And the saddest case I've read about, I'm going to call her a young girl of 12. So thankfully that's, very, very rare, but it just demonstrates it can still happen. So every single person in your business, whether that's directly or indirectly, seen or unseen, will encounter menopause. So think about, women of the world, we're insidious, aren't we? We're everywhere. There's no escape. So it could be colleagues, it could be friends, it could be family members of yours. And I'm doing an awful lot of my work, or have done in the last 12 months, in very male-dominated businesses. So think about those male colleagues in your business who might be starting to come in late on occasion, and they've never been late before. The root cause could be they're living with menopausal wives, partners, and girlfriends who are not sleeping, and neither are they sleeping. So what impact impact might that have on their productivity? Are they drivers? Are they operate equipment, machinery, etc.? What about young people? We know statistically women are having children later in life. We know that's a statistical fact. And we know that a lot of young people can ill afford to leave home because it's too expensive. So what about young people who are living with menopausal mothers? So I had an interesting conversation not too long ago with a young woman who came to one of my sessions who said, Sharon, when I was leaving work, my mother threw a butter dish at my head. And I was like, well, that's not a common symptom of menopause that I've come across. And it turned out what's really interesting about menopause also is many of us might spot the signs and symptoms in others long before they spot signs in themselves. And a really interesting thing about menopause is, I don't know if anybody on the call loves a process, but menopause isn't one of them. And the really important point I need to make to you is this. Symptoms of menopause will usually occur months and even years before the individual has noticed a change in their periods. Now, that's if they're even having them. Now, many women in the 21st century, again, quite rightly so, will tap into contraception. Mirena coils, as Emily's just mentioned, Depo injections, mini pills, which means they aren't even having periods. So how on earth are you supposed to know that what's happening here could be linked to this menopause thing here? So I want you to think about it like this, that every single person in your business will encounter menopause directly or indirectly, seen or unseen. So this is the business issue. And ultimately, what you want to do, the most expensive cost in any business is people. So it costs a lot of money to attract them, to bring them on board, to train them. And you want, when you've got a good person, you want to retain them for as long as possible. So really, this is why you hear shocking statistics like 1 in 10 women are thinking of leaving, but we're not even talking about the impact this has on men and your male colleagues as well. So think about menopause as having tentacles that reach into the corners of every single person's life. And this information can't harm anybody, but I truly believe it can help absolutely everybody. So what could you do from a company point of view? Well, from a strategic point of view, I always say start with the end in mind. What is it that you are trying to achieve? Now, in a previous life, I used to be a senior leader in a FTSE 100 company. I used to think I was really smart and I was really streetwise. And this company, like many, many others, we'd maybe say, right, 2024, what we're going to do? We're going to do a big initiative on menopause. And we do lots and lots of things this year, and we'd learn lots of things. And then something new and sexy would turn up in 2025 and we'd kind of ditch menopause, and then we'd do something else. And then a couple of years later, somebody says, shall we do something about menopause? And your workforce go, oh, not that menopause thing again. So how are you going to embed this in your DNA? So one of the most important things I think about building a strategy is to really build in your maintenance plan at the time you're building your strategy. So menopause doesn't become just an event that happens, over a period of time, on a year, on a couple of occasions. So think about how you are going to build a maintenance plan. So an example I would give you, say if you had 1,000 heads in your business, It might take you strategically between 3 and 5 years to embed something like menopause effectively if you're going to include everybody in the conversation. So at year 5, let's say you've run 4 sessions every year for 5 years. And at year 5, what we need to be doing is we need to be looking at, are we in growth? Are we flat? Are we in decline? So if you're in growth, you might have acquired several more companies in the last 5 years. You would need to repeat the same exercise again. If you're flat, rather than having 4 sessions a year, you might only need 1 a year through attrition. So it's really, really important before we set off and think about, are we going to build this into our business? Will it become part of the DNA of our business? Or is it in danger of just becoming an event for a moment in time? You also really need, when you're building that strategy, to get your senior team to buy into that. And really, exactly what I've just said to Emily, it's about building role models who are going to be vulnerable and who are going to share their own stories. Because that is the goal. Just if you get senior people in your business, and this doesn't just apply to menopause, this applies to any well-being, AD&I topic, and tell their own human story, it can be transformational on how you get your people to respond. And then that starts to unlock the doors for others to enable to tell their own story. And that doesn't cost you anything. But what it really shows is you've got a culture of psychological safety and people who are in charge putting their money where their mouth is. And I think unless they're going to do that at that senior level, I think we're going to struggle with embedding any real strategic approaches in any business. I think it's also really interesting that you should build clear accountabilities into your business onboarding, into any policies or procedures that you're writing. And I'll tell you a really interesting story. So I've been working with some big brands in the last 7 years, you know, from Starbucks, KFC to Siemens, very male-dominated businesses. And what I've done is they've often asked me to look at their policies that they might have written, which are all well and good. But let me tell you, on 100% of occasions, I have never seen a policy that indicates what's expected of the employee. So I almost feel that lots of businesses are in danger of creating lots of prince and princesses who are going to knock at your door and go, well, I've got this policy and you've said you're going to do all of this for me. But it doesn't say anything in those documents what the business expects of the individual. And I always say in the work that I do, unless it becomes an equal active partnership where both people in that relationship are accountable, it's never going to work. So just look at some of your fundamental foundations in your business, like your policies or your procedures. They may be causing some of that behavior because it's just not clear to individuals. I'm quite controversial in this space. And what I would say is, yes, champions exist. And yes, if champions are recruited well and you've got a robust process to recruit your champions and you understand what the value of those champions are, I think champions have a place in the world. But what I've found with a lot of companies is champions becomes a way of outsourcing bad behavior of certain managers. So rather than tackle, I'm going to pick on Johns of this world, rather than tackle John, who's maybe been in your business for maybe 10 years. And John, people say, John, he's a good guy. He's really good. But let's imagine I want to disclose my menopause to John and he goes, no, with this problems, don't want to hear, don't want to hear, don't want to hear. Now, I accept that 5 years ago, we weren't talking about menopause, we weren't talking about PMDD, we weren't talking about neurodiversity, we weren't talking about a whole lot of stuff. So what we have to be fair to John is we have to educate John and expose John to this information, this new world that we're in. But if John has had that information and he's still not doing it, it's either because he won't or he can't. So it's a skill, we've called the skill, it's a will or it's a capability. Now, I'm certainly not saying that moving John on is an easy thing to do. I absolutely know, like I say, I used to be a senior leader in the FTSE 100 for 14 years. I know it's not, but it probably is the right thing to do in the 21st century. So rather than building a load of champions around the Johns of this world and outsourcing his bad behavior, think about why you're having champions and really, really, again, build that into a strategic approach. What is the purpose of those champions and why they're having them? Training of managers. Do all managers have to have this training? Now, I'm not a one for forcing managers into training, but if you think these things are important enough to be part of the DNA of your business, then maybe, again, there's a strategic case that everybody at a certain level needs to have this information. It becomes not a nice to have, it becomes an essential thing to have. And the thing is that I've decided to do over the years is everything that I do, it's not built specifically for any one community. So the work that I do isn't suitable just for managers or non-managers, male or female. I've designed the sessions that I run to be completely inclusive, where anybody and everybody can come along and learn about this at the same time. I want us to build simplicity into our businesses. And I think a lot of people out there are even say IPD, they're saying, write a policy for everything. I'm saying policies have a place, but my view is if you write a policy for everything, especially around mental health and well-being, are you in danger of being exclusive rather than inclusive? I just want to explain myself. So if, for example, you write a specific policy standalone just for menopause, could you be excluding people like John in accounts who's got diabetes? What about Joan who's got cancer? Have you written a cancer policy? Have you written a diabetes policy? So why is a lot of fear being sold into this place where you have to just have specifically a menopause policy? I'm much more of a fan of writing a generic process, policy, well-being plan, whatever you want to call it. And I've made up a word. What about if you were to menopausalize, see what I did there, your current processes and stitch menopause into your current processes? So an example would be, you might stitch it in your return to work policy or your return to work process. Because if somebody's late or if somebody's off sick, the root cause could actually be menopause. So all we're doing with these topics is we're giving your managers, your communities and your businesses an understanding of what the root cause of their behaviours may be. So it may be PPMD, it may be menopause. So what I'm saying is, and another example, I'm doing a lot of work in manufacturing. So what about your uniform policy? Now, when your uniform review comes around, it might not be this year, it might be next year, or even 3 years down the line. When you're doing that review, are you going to consider the design choices of those uniforms? So I'll tell you a really interesting story. I was in a manufacturing site and the woman had been complaining that some of them were getting really hot. It turned out they were menopause-related symptoms. And they had hoodies. They were great hoodies. They were marvellous hoodies, but they could only pull them over their heads. So remember, simplicity is the key. They said, could we have some hoodies with a zip? So all they have to do is unzip them and they can wear the hoodie and it feels much more comfortable. So again, you might consider zips, you might consider the fabric choices of some of your uniforms, just because you're starting to see the world through a menopause lens. So really what I want to say is, if you set out clear accountabilities, if you include everybody in the education and the conversation, if you can get people to begin to tell their stories and extract that gold dust and keep it really, really simple, then that is it's really how you're going to engage your people to enable menopause like this to become business as usual. The minute you have a standalone policy, the minute you start adding layers, complexity into your business, I think you're in danger of getting what I call a management or a leadership eye roll, where your managers are going, oh, got all these things to think about. And it seems so terrifying and scary. So I want you to think about how you can show your managers what's the same, not what's different. And a great example of that would be, I'm sure most of you on this call have a great process for the disclosure of pregnancy. So let me use this example. So if I disclosed a pregnancy in your business, what might you do? Well, I might get a car parking space near the office. I might get a workstation assessment, and you might give me a desk fan, a footrest, whatever. You might give me time off for appointments. So what I'm saying to managers and leaders of the world is, think about what's the same, not what's different. So all you have to do now when it comes to menopause is look in your small reasonable adjustment toolkit and flip and apply the processes that you already have to menopause. And I'm going to end what I've got to say with a really daft story. So it was almost when I set up Miss Menopause about 6 years ago, nearly 7 years ago now. And I'm kind of powering down the office because I'm going to do a menopause session. And a woman leapt out of me and she said, Sharon, I think I'm going through the menopause. And I went, all right, okay. She went, I've asked for a fan. Now, in my mind, I said, well, that doesn't sound unreasonable to ask for a fan. She said, because I get really hot. And I said, all right, okay. She said, my managers checked the policy out. They've looked at the process. It says I can have a fan, but only when I'm pregnant. So this is why, if we can menopausalize our current processes and join them together, that is a much more simple way and effective way of making menopause business as usual. So I'm going to hand back to Emily and say, has anybody got any questions? I think we've got a whole, 3 or 4 minutes left.
Yes, so let's have a little look. So Claire says, can you explain the concept of a menopause calf? I know Emma has popped something in the chat box about that. Have you got any comments on menopause calves?
I think menopause cafes are a great thing, but again, I'm controversially going to flip it on its head. So example I'll give you. So I was working with a big NHS trust, 8,000 humans in the trust, and they said, we've got 300 women currently in the menopause cafes. And I was going, that's brilliant. I've even spoken at those cafes. But my question was, what about the 7,700 people who aren't coming along? So I think it's great for menopausal women who are desperate for more information. But what about everybody else? How are you going to engage those who are choosing to stay away? That's what I would say about that.
Thanks, Sharon. I have one question. You mentioned right at the start about the first 100-day changes with the new government. Is there anything that you know to give some insight into employers around what this menopause policy expectation is going to be like?
Nobody really knows. The only thing that we do know, they're talking about companies with a headcount of 250 plus, and they're saying it could be reporting like gender pay gap initiatives. That's what's being cited at the moment, but nothing of any concrete evidence is coming out of what. So I guess we'll just have to all wait with bated breath and see what happens.
Yeah, sounds like it. So I know people are starting to dwindle off already. So just to finish off, if you do have any questions, this is where you can contact Sharon and ask them yourself. So her website is missmenopause.co.uk. You can link in with her on LinkedIn. I'll send her direct link in a follow-up email. And of course, you can email her at sharon@missmenopause.co.uk as well. Just a little reminder for those who may be interested in the level 5 diploma, enrolment is now open. I will follow up with the leaflet and information on the diploma. Enrolment closes in about 37 days' time, and the course starts in September. So you will be expecting from me a follow-up email with all the information to contact Sharon for more conversations with her directly about menopause and what support she can provide for you. You'll also find in that email our PMDD guidance document as well. And I just want to say thank you so much for coming today. Thank you to Emma for leading us in with PMS, and a huge thank you to Sharon. You know, I hope you all have a great afternoon, and hopefully we'll see you again at another wellbeing webinar from Our Minds Work.